stock up on your Robitussin and your Dayquil, friends. We're going to be talking about COVID-19 and what it did to the healthcare system in general. My name is Allison, and this is Stretcher Fetcher's podcast. Once again, I'd like to remind you that none of my statements or my opinions are affiliated with my department. So without further ado, let's get going. Hollywood has put out so many movies on pandemics and outbreaks that have shut down the entire world's operations. And yet, the world had such a hard time processing that we now had a pandemic, COVID 19, that was a realistic thing that was coming into the United States. It was taking over the world, and nobody really knew how to react. So I think that we were extremely underprepared for what came about in 2019 and early 2020. I know that that was not something that I ever considered happening when I was working in the healthcare field. I wasn't very heavily into fire and EMS at the beginning of COVID 19. So some of my experiences are going to be reflecting on how COVID 19 has just changed in general how we've handled healthcare. But it was a really crazy time. We were basically in this very unique position where we didn't really know what to do. We were kind of making it up as we went along. And there was a lot of resistance against the World Health Organization and the Center for Disease Control. I was surprised by how many people did not want to adhere to the new guidelines that were coming out. One of the biggest changes that was a shell shock to me was the PPE changes. And as first responders, we are at a higher risk of infection because of the nature of our work. But with proper protection, we can prevent transmission. Other studies have shown that respirators adequately protect the wearer against viral particles, and we became more likely to triage better and alert the first responders to PPE advisement to try and get ahead on lessened exposures. I find it crazy that before the pandemic, there was times where I would get dispatched to a class 1 and all I had on was a pair of gloves. That's it. I had very limited knowledge of aerosolizing particles in the patient's lungs and the airway. Obviously, I knew that vomit and blood was gross, but that just came with the call risk. And we just made sure to get it off as soon as you got back to the station, or you tried to decontaminate yourself as soon as you got back to the truck and make sure that you wipe stuff down. I knew that we were wiping down our Lucas and we were cleaning everything really aggressively, but that was pretty much just following cardiac arrest. We were not necessarily wiping down everything after every call. At the hospital, we had these Sandy wipes, and shout out to Sandy wipes because those are the true healthcare heroes of this whole service. But to be fair, we didn't know anything about the virus at the beginning. It kind of felt like when we were going to calls that we were just choosing who could afford to get sick. People that had families and young kids, elderly parents at home, they were kind of told by the other responders that they should be the ones to stay in the truck. So, in a way, it kind of felt like the Hunger Games at first, if I'm being honest. But you would send one provider in to be in proximity with the patient, they would triage, they would get exposed, and they would let the other providers in the truck know if they needed additional help on scene. It wouldn't make sense to alternate who was going in with the airborne precautions patients, because if you already had one person exposed, you might as well just keep utilizing that person for the duration of the shift. So they were kind of running all of the respiratory precautions that night that we were on call. And I definitely remember coming back from calls and work at the hospital. We made a makeshift work closet for me and my sister. She was a respiratory therapist working in a vent unit. And I'd strip in the garage and change into a new pair of clothes before coming into the house. I would immediately run back and shower or do whatever I could to reduce the risk. I was living with my parents at that time. I was trying to prevent my family and my parents from being exposed. I think that my grandma had a really hard time processing that if I had a known exposure that I did not want to come over and expose her to that. So I had a 72-hour rule where if I was exposed within 72 hours of when I had planned on visiting her, that we canceled that visit and rescheduled it. I also had a husband who was my boyfriend at that time, and he had really bad asthma. So I think we went like a month straight without seeing each other because I wanted to do everything I could. He was basically wearing a mask at work, and my sister, she would come in from the vent unit. She would change her clothes. She would text us that she was coming home because she was working night shift. We would either stay in the kitchen or respective rooms, and she would immediately go back and shower and come and join us after that. My parents, my dad was a teacher, so obviously he was staying home, and my mom was able to work from home at that time. So thank goodness that we were able to avoid a lot of the exposures. But a lot of people were skeptics. So many people still tried to deny that COVID-19 was a problem and even real to begin with. And that contributes really heavily to first responder and medical personnel's mental health during this time. Because as someone that was working in the hospital system, and knowing that people were limited from seeing their family couldn't understand why they could only have 1 to 2 visitors, and that people were dying alone. um, we set up a lot of like virtual FaceTimes and as much family as we could. But I remember picking up extra shifts at the hospital literally just to roll gowns and bring bodies to the morgue. So to hear people like out loud having the audacity to say that COVID-19 was just the government trying to control us was so crazy. There was just people that were like blatantly not wearing their masks, and they would pull them down as soon as they would get into the patient's room. And you would say like, "Hey, please pull up your mask, like this is a rule." And they would just refuse. So we would have to pull in security, and a couple of my coworkers were borderline assaulted because people did not want to wear masks. So we had to have security personnel that was just rounding for people that were denying that they had to wear a mask. And so we were offering people the virtual visits, and we were saying that we were willing to reschedule their appointment if they didn't want to wear their masks, but they were coming from a point where the government was trying to control us, so they wanted to keep their in-person appointment, but they didn't want to adhere to the rules that we had no mask, no service. Now, I wasn't heartless. If I had a patient that had trouble breathing, if I had a patient that like you could look at them and visibly see that they were having a more difficult time functioning, I would just let them know, like, hey, I would like you to put on your mask when I get near you to assess you, but I can deal with you not wearing your mask as long as you cover your mouth, and we're both gonna decontaminate ourselves a couple times within our interactions of each other. And you could tell who truly could not wear the mask and who was defying the request for people to wear masks. We had family members that had to get kicked out because the worst offenders were the family members. They would come into their patients' appointments and they would just refuse. And we're like, listen, you guys are not mandatory personnel here. If you cannot adhere, we're going to have to kick you back out and we'll try and keep you in the loop. But yeah, it was a big fight in between emergency personnel. And when we're going into people's houses, they might have thought ahead and put on a mask, but people weren't describing their full symptoms. So anybody that had shortness of breath, anybody that had chest pain, anybody that had weakness or fatigue, we were automatically putting on our gowns and our masks. It started getting a little bit more lax the longer that COVID went on, but I think that we jumped the gun with really being overdressed for these occasions. Um, As healthcare providers, we understand the science behind recommendations and we saw firsthand how devastating the virus could be. But our job is not only to help those in need, but educate those that we're facing with the tools that we have to combat it. So we were letting people know and not just saying, well, you have to wear your mask because you have to wear your mask. Um, there was really fatiguing times where we would work 60 to 80 hours because we were picking up overtime in the hospital due to influxes. We were doing the weekly and daily COVID tests as requested. The first responders and medical professionals were kind of like the guinea pigs for the vaccine when it first came out. But it kind of really highlighted how unprepared we were for a pandemic. Ironically enough, many emergency agencies had reduced call volume compared to the years before, and studies show that there were reasons for this decrease. A lot of people actually valued, is it worth going into the emergency department? Do I need to risk the exposure? Like, there are other people that need these hospital beds. And now that the big threat of COVID is done, you're noticing that a lot more people are more likely to just go to the hospital because it's the easiest way to go about things. I have separate opinions on that because I believe that we do a poor job in general of educating the public on how to utilize the medical system. But, anyways, COVID-19 showed us the many areas that we were not prepared to handle a pandemic. First, being the lack of sufficient equipment, and that is just one example. We experienced feelings of fear and frustration when we realized that masks that were intended to be single use were going to be reused and they were going to be reused until they were visibly soiled. We would put our masks in plastic or paper bags and they would sit at our desk with our names on it. We didn't even start developing masks that had the mouth space with a panel over top of it for our hard of hearing patients. So I really truly feel bad for them because we all experienced all of these unknowing like sense of doom. Like, I wouldn't normally be someone that would get nervous around someone that was sick, but I was actually getting like uneasy when someone was not well because we just didn't have enough knowledge about what was going on and there wasn't enough PPE to go around. Our N95s were the biggest ones that had to be reused on a regular basis, and that shouldn't have happened. Our next step that we learned from this experience is that the hospitals, the states, and the healthcare organizations, including EMS agencies, need to prioritize preparing and stockpiling protective equipment for the next big illness. The next pandemic isn't an if, it's a when. And if we have people, this is me getting on my soapbox, but if we have people that are continuously denying getting vaccines and they're not vaccinating their children, we are going to bring back diseases that we had eradicated and we got in a controlled substance where we could administer vaccines. And people are denying science and they're saying that it all comes down to your health and nutrition. Well, yes, that does play a huge part in you overall staying healthy, but you can't build up resistance against polio and RSV and all of that stuff without the assistance of medical developments. So, if we have another pandemic in the near future, because it is something that rears up its head when it is cold out, this is a disease that's constantly developing. So we're always one step behind. If you guys have known that with the flu vaccine is based off last year's round. So we don't necessarily have enough information and we don't have enough antibodies against the new developments of flu. So we're always just behind the eight ball. But the COVID vaccine was one of the first vaccines that piloted using mRNA, which is a breakdown of the proteins inside of your DNA. And they actually did a genetic study and looked at the DNA of COVID to develop the virus and the vaccines warnings and protections. So we started working on that obviously in 2019. The medical field is always one step ahead, but not necessarily publicizing it. So we knew that it started overseas. A lot of people said that it started in China, but there was probably registered cases in the United States and we just didn't have a name for it. So we categorized it as the flu. A lot of the times, like the flu didn't really exist during COVID. You had a gastric bug COVID or you had the respiratory bug COVID, but you'll notice that a lot of other diseases didn't necessarily get diagnosed at that time. And whether it came down to insurance that was giving claims for people that had COVID and had deaths that were related to COVID, or if we actually genuinely just classified everything as COVID because we didn't have enough education, there was a new DSM code that was added just for COVID-19. People were dying because they were waiting until the very last minute where their symptoms were so bad to the point that they couldn't breathe or they were super fatigued and they couldn't get help in time. It messed with people's blood sugars. I had a lot of patients that went into diabetic ketoacidosis during COVID, and the class 1 restrictions kind of changed for a while there. I know that it kind of reverted back to 10 minutes of BLS provider care, and then you could provide an extra 10 to 20 minutes of ALS care. But the times that we were working patients were basically cut down to half. And there was a lot of times that we had to say that the patient was not going to be transported and that we were cutting the cardiac arrest short, which was heartbreaking. But we did start to develop new technology that helped with triaging. This really rolled out in the hospital system to begin with, but there were other states besides Michigan that started to follow suit. I'm sure that virtual visits was a thing before COVID, but telemedicine was severely underutilized prior to COVID-19, and that is almost certain to become more common in the future. There was a lot of patients that were rolled up, and if they were deemed not necessary to come into the office, they were transitioned to a virtual visit. I was working in orthopedics at that time, so we were trying to get them to have local x-rays and not come into the office so we could limit their exposure, which kind of didn't make sense in my head because we're still sending them to an office. We're just not bringing them into our office. But I mean, like I said, we were developing at that time. Telemedicine quickly became a clear solution to a lot of these patients that needed to get in. We would have entire days of virtual appointments where we would get people signed up for surgery and we would do follow up on wound checks and have them send pictures. We would do notes to home nursing care, and virtual appointments allowed patients to get advice from physicians without exposing everyone in the waiting room. The sucky part was is that a lot of the people that benefited from the virtual visits, like the elderly populations and the people that had to facilitate ride transports, they typically didn't have the technology information. So there was a lot of very detailed virtual visit instructions. I had to help a lot of elderly patients set up their virtual accounts and tried to make it as foolproof as we could, but there was a big disconnect. A lot of people, if they lived up north, we called it the Central Michigan Dead Zone or the CMDZ. But if they lived up north and there was not a lot of access to internet, that they would basically have to go to like McDonald's or a library or something like that and try and steal their Wi Fi for the virtual visit, or have a family member come over and facilitate that. So there were some deficits to that. And when we would have to coordinate virtual visits with nursing staff, they would get overloaded with the patient volume and end up having to delay or reschedule the visits, which that was frustrating, but also there was a big deficit of people that were not in the healthcare or they retired early and took packages. So the entire healthcare system was short staffed to begin with. And it kind of left our elderly populations out to kind of fend for themselves a little bit. Well, hindsight is 2020. The question now becomes, why did we wait for a pandemic to shine light on regional communication and its gaps? Between med control systems, remote provider to patient video calls, we should be strategizing how we build a telecommunication relationship between organizations that is easy to maintain and support. Texas is rolling out a virtual visit EMS call where when you call, you can get triaged and they can actually tap into your video camera and they can see what you're describing. So it's not necessarily as much a game of telephone as it is they're physically sending these images to the EMS providers and getting higher quality care and diagnosing so that they're getting more appropriate med levels. Telemedicine has historically been underutilized in EMS, and we should take advantage of this in the future. Companies have developed applications that allow EMS providers and patients to communicate directly with hospitals and physicians, and this helps them develop treatment plans and provide the best care for the patient. Instead of necessarily bringing them to a hospital and ER waiting room, you can get connected with a nurse navigator and a physician assistant, and they can actually advise whether the patient even really needs to come in or what they need to do so that they can get better. We need to be taking a proactive approach to having regional system of care instead of waiting for these emergencies to happen before we turn around and rush to build a program that hasn't been beta tested. The dependency on technology wasn't just on a patient and provider level. It was a big shock seeing families FaceTime with CPR in progress. I was working a patient and I remember looking off to the side and seeing someone that was FaceTiming a family member and hearing the cries of disbelief over the speakerphone, constantly having to talk to the patient and the family member that was also on the phone. So you would be double explaining everything. Visits would be twice as long. And then you'd have frustration from people that had a virtual appointment that didn't know that there was actually patients in the office. So they would get impatient and they would get frustrated with the staff. Virtual visits were a blessing and a curse at that time. Overall, I think we have a lot of value and a lot of take back from our first big experience of a pandemic with today's day and age and technology. And I think that we have a lot to take back and move forward with developing more efficient care for our patients. But that concludes today's topic. I hope you guys are all staying safe out there. Keep being awesome. And if you guys like what you're hearing, make sure to give Stretcher Fetchers a follow. I am also on YouTube and Apple Podcasts. So make sure that you support the mission. Anyways, thanks for the listen, and we'll touch base next week. Bye.